So Jeff is here with us today, and we are actually putting the grafts in the frontal hairline. Hairline design is very crucial to give a natural appearance of the hair transplant. So one of the simple tests for us to know how far should we go with the hairline is to ask the patient to raise his eyebrows up. So if you see the creases of the frontalis bellies on both sides, this is where the creases end. So actually that gives us just a rough idea where the actual natural hairline is. Another quick trick as well is to use 4 fingers over the same patient. Put the fingers parallel to the eyebrows, and when it ends, usually that marks the tip of the widow's peak, like they call it. Okay, you can put it down. The other thing is that after we do the hairline design, we have to do the hair placement at an irregular fashion, like a zigzag or a little bit of islands. In his case, we're going to do replacement and increase the density of the vertex, as well as the baldness in the posterior end. We actually just removed the strip recently, and we closed the turn your face this way with trichophytic closure. You can actually see the incision line, and we just cover it with hair, so when he walks out of the office, as if nothing happened. As we try to numb the recipient area, there are 2 techniques that I like to use. The first technique is supraorbital supratrochlear blockage, and we ask the patient actually to relax back. We just feel the foramen in the supraorbital rim, and right where the foramen is, I'm going to just place about 0.5 cc's of the lidocaine with epinephrine 2%, and just let it sit for a few minutes. Usually it takes up to 90 seconds for this to take effect, and that should start numbing the whole entire area here. Little pressure. How are we doing?
That's fine.
Okay, perfect.
As always.
So the posterior area already has been numbed because we took the strip, and that kind of numbs the branches from the occipital nerve, or the posterior branch of the occipital nerve. So now we start with the frontal area, and the technique that I usually use some distraction, either a vibration or touching, and we just do a little bleb at the frontal hairline, and we inject it very slowly, because rapid pressure is what causes patients to feel a lot of discomfort. So this is our entry point. From this entry point, we're just going to use hydrodissection. We go very superficial, and we let the anesthetic just dissect through the entire hairline, and we proceed very, very slowly. We leave this area, we come from the other side, while that side numbs up. Usually it takes about 90 seconds for the lidocaine to have full effect of numbing, while epinephrine takes up to about 20 minutes to give you a full vasoconstrictive effect. So again, we let it proceed slowly. How you doing, Jeff?
Oh, just fine. Don't feel a thing.
That's a great patient. As we see, we're starting seeing the vasoconstrictive effect of the epinephrine here. We start where we ended, and I use a 27 gauge long needle. Again, I keep switching both places to make sure that we give enough time for the anesthetic to work. So these 90 seconds is very efficient in allowing this anesthetic to work fine. So we keep switching both sides as we come out. Now that we numbed the frontal hairline, the second step is to use mild tumescence. Okay. So I like as well to reinforce my anesthetic using some Marcaine because Marcaine gives the long-lasting analgesic effect for patients in the post-operative period. So you don't need a lot of analgesics or a lot of codeine to be used in the post-operative period. I give very good pain control. And again, we use the entry points from an area that's already anesthetized, as you see. Give me photograph, please. Thank you. Come on. Do a little bowling. We don't go very deep, just to allow good tumescence of the scalp and easier placement of our grafts. This is actually our grafts. As we see, we categorize the grafts to 1, 2, 3, 4 hair grafts, and a little bit of bigger punch grafts that we use for just coverage of the central portion of the vertex as well. As we see, the area here is completely blanched because of the epinephrine effect. So the next step I'm going to do is to tumesce the vertex area with epinephrine to allow good tumescence of the back. Where we're going to be placing the scalp in the vertical or in the vertex region. Jeff is a wonderful patient.
There is no discomfort to this at all.
So hopefully your patients will be as good as Jeff as well, and they don't feel much discomfort. We usually do not use any oral sedation in the office procedures. But if you decide to use some sedation, then you have to be in a surgical facility. This is the vertex is very important that we make sure the direction of our placed hair follows the direction of the swirl of the hair. So as we put down here the arrows where you have to put your hairs, or the grafts that we place should be following the swirl of the vertex. As well, we have to make sure that when we place our grafts, we have to as well predict that there might be some progressive loss, so we would not have this crescent effect or have a halo effect around the grafts that will grow in the future. So we just follow with arrows the direction of the hair, and this is just for demonstration of the direction of the slits that we're going to be placing. So we're starting doing the slits that we will place our grafts in, and for that we use 26 blade to give density. We don't need to have micrografts in this area because it's not a hairline. As you see, we're placing the slits or the orifices parallel to the arrow direction. So when the hair grafts grow, it will follow the direction of these arrows. We are halfway in the process of placement of the recipient slits, and you can see the direction was following the arrows. Here is going forwards, here is going backwards in a swirl, and this is outwards again. And then we continue to do our placement for recipient sites. Now there is a completion of placement of the mini grafts that we have at the vertex, as well as the frontal hairline.